Hello viewer, Assalamu alaikum. So once again, welcome to my new lecture. Today we will discuss about the heart failures and its management. So heart failures is one of the cardiovascular disorders which results from any structural or functional abnormality that impairs the ability of the ventricle to eject the blood. Systolic heart failures are to fail the blood, or diastolic heart failures. So this is the vicious cycle of congestive heart failures. So what actually occurs? So in congestive heart failures, you can see here there is occurs left ventricular dysfunctions causes decrease the cardiac output and decrease the blood pressure, as well as decrease the renal perfusions. Now let's see here. There ultimately, so it can stimulate the release of renin, which allows the conversion of angiotensin to angiotensin 2. So angiotensin 2 stimulates the aldosterone secretion, which causes retention of sodium and water, increasing the filling pressure. So as a result of the left ventricular dysfunctions causes decreased cardiac output. And when the cardiac output decrease, it means that the supply of the blood to our hearts become decreased. So as a result of renal perfusions and many more complications, so the vicious cycles must be adopted due to this condition, like stimulations and release of renin. Okay, so now come toward the type of heart failures. Heart failures can be divided into different parts. When there is low output heart failures, for example, systolic heart failures and systolic heart failure, there is decreased cardiac output, decrease the left ventricular ejection fraction, while in diastolic heart failures, there is elevated left and right ventricular and diastolic pressure. So may have narvals, LVF, left ventricular ejections fraction. The second one is high output heart failure. So in high output heart failures, it can be the seen with peripheral shunting, low systemic vascular resistance. There may be hyperthyroidism, anemia, and often have normal cardiac output. In right ventricular failures, it is seen with pulmonary hypertensions and large RV infarctions. What are the causes or clinical etiology of low output heart failures? One is systolic dysfunction, in which that is also known as coronary artery disease, and coronary artery disease in which it causes idiopathic, so dilated cardiomyopathy, that is also called DCM. 50% idiopathic, at least 25% that is familial, so 50% its cause is unknown. In 90% there may be chances of myocarditis, it may be viral. Ischemic heart disease, hypertension, HIV, human immune deficiency syndromes, and connective tissue disease, substance abuse, and doxorubicins. Hypertension, this is another cause, valvular heart disease. So all these are the causes of systolic dysfunction. Another one is dystolic dysfunction. So in dystolic dysfunction, which is always occurs due to hypertension. It may be due to coronary artery disease, may be due to hypertrophic obstructive cardiomyopathy, that is called HCM, and you can say restrictive cardiomyopathy. Now here the clinical presentation of heart failures, which is occurred due to excess fluid accumulations like dyspnea, most sensitive symptoms, edema, hepatic congestions, ascites, orthopnea, paroxysmal nocturnal dyspnea, that is also called PND, and sometimes the heart failures may be due to reduction in cardiac output. So its main cause is fatigue, especially with exertion and weakness. Come toward the physical examination on heart failures. So S3 Gallups. This is low sensitivity but highly specific. So you know, this is there are different type of sounds of heart, like club dub contraction and relaxation of hearts. So first, second, and different sounds of hearts, so which are felt during systolic and diastolic pressure. So cool, pale, and cyanotic extremities have sinus tachycardia, diaphoresis, and peripheral vasoconstrictions. Crackles or decreased breath sound at base effusion on the lung exams. Elevated jugular venous pressure and lower extremity edema, ascites, hepatomegaly, and splenomegaly. So all these are you can physically examine the patients, especially in heart failures. Lab analysis in heart failure, there is CBC, complete blood count, since anemia can exacerbate heart failures. Serum electrolytes, creatinine before starting high dose diuretics, fasting blood glucose to evaluate for the possible diabetes mellitus, and thyroid function test, which is also very important parameter, since the thyrotoxicosis can result in a FIB, and then you can easily determine it may be due to hypothyroidism, can result in HF. Since the thyrotoxicosis can result in arterial fibrillations, and the hypothyroidism can result in heart failures. Iron studies are also under investigation to screen for hereditary hematochromatosis, can cause of heart failures, and viral studies, if viral myocarditis suspected. So laboratory analysis, so BNP with chronic heart failure. So BNP is natriuretic, you can say peptides. So with chronic heart failures, arterial muscles secrete increased amount of arterial natriuretic peptides. That is also called, you can say, INP and brains. Natriuretic peptide BNP in response to high arterial and ventriculars filling pressure, usually is greater than 400 picogram per ml, and patient with dyspnea due to heart failures. So chest X-ray in heart failure is also one of the important parameters. So there is cardiomegaly, cephalization of the pulmonary vessels, and curly lines, pleural effusions. Look at here. So these are the different conditions which you can see in X-ray. Cardiomegaly. So you can see the cardiomegaly is the condition, and with the size of the heart become abnormal. So you can see here this cardiomegaly occurs. This is the wall. It's not clear, but as you know, the cardiac heart is located posterior to the sternum in the mediastinum cavity. Cardiomegaly. Okay, pulmonary vessel congestion. So this is pulmonary vessel congestions. These are the variety of conditions. So pulmonary, and with the blood vessels especially the blood vessel directed to the lungs, so that it become congested, it become narrow. Pulmonary edema is due to heart failure. So pulmonary sometimes edema, swelling, especially at the level of lungs, due to heart failure. So you can see here in this X-ray. These are curly B lines. These are the curly B lines, which is also the clinical investigation for hypertensions. Okay, so now come toward the cardiac testing and the heart failure. So cardiac testing and heart failure is first of all you have to use electrocardiograms. Electrocardiograms measure specific cause of heart failures, ischemic heart disease, or dilated cardiomyopathy, or you can say idiopathic dilated cardiomyopathy, or you can say cardiomyopathy, and LVH. Or echocardiograms, left ventricular ejection fraction, structure, valvular abnormalities. Further cardiac testing and heart failure is exercise testing, so should be a part of initial evaluation of all the patients with congestive heart failures and coronary and arterioscopy. So it should be performed in the patients presenting with heart failure who have angina or significant ischemia. Measured cardiac output, degree of left ventricular dysfunction, and left ventricular end-diastolic pressure. Further testing in heart failures, there are endomyocardial biopsy, which is not frequently used, really only useful in cases such as viral induced cardiomyopathy. This is another class, you can say, the classification of heart failures. According to the New York Heart Association's NYHA, so in class 1, especially in class 1 heart failures, no symptoms and no limitation in ordinary physical activity, shortness of breath when walkings, climbings, or stairings, especially stairs when you go upstairs. So in class 2 there are mild symptoms, so mild shortness of breath and or angina in slight limitation during ordinary activity. So in class 3, marked limitation in activity due to symptoms even during less than ordinary activity. For example, walking short distance 20 to 100 meters, so comfortably only at rest. While the class 4, there is severe limitation experiences symptoms even while at rest, so mostly bedbound symptoms. Now come toward the chronic treatment of systolic heart failure. So there should be a correction of systemic factors. First is thyroid dysfunctions, infection, uncontrolled diabetes, and hypertension. Lifestyle modification is mandatory, so lower salt intake, alcohol cessations, medication compliance, and maximize medications. Discontinue drugs that may contribute to heart failures, like NSAID, non-steroidal anti-inflammatory drugs, or anti-arrhythmics, calcium channel blockers. Order of therapy is you can see here, so which we have listed. These are the 6 top list order of therapy. So the first choice is loop diuretics, then ACE inhibitors, or ARB if not tolerated, then beta blocker, then you can say digoxin, then hydralazine nitrate, and potassium sparing diuretics. So first of all, we will talk about the diuretics. So as we know that diuretics are those drugs when they are given to the patient, so it can enhance or increase the urine secretion. So diuretics, the first one is loop diuretics. Loop diuretics include furosemides and butynamides. So as we know that furosemides, so they are available in a market by trade name Lasix for fluid control and to help relieve symptoms, while potassium sparing diuretics include spironolactones, eplerenone, and it help enhance diuresis, maintain potassium, shown to improve survival in CHF, so congestive and congestive heart failures. Then come toward ACE inhibitor, angiotensin converting enzyme inhibitor, so it can improve the survival in the patient with all severities of the heart failures. Begin therapy low and titrate up as possible. And Lapril, so as we know, Lapril that is available at a dose of 2.5 mg per orals daily. Captoprils, all these are AC inhibitors. So captopril is also available in 6.25 milligram per oral. 30s, you can say 3 times a day. Lisinopril is 5 milligram per oral daily. If can't tolerate it, so maybe try ARB. Okay, then beta blocker therapy. So certain beta blockers like carvedilol, metoprolol, bisoprolol can improve oral and even free. But these beta blockers are contraindicated if the heart rate is less than 60 beats per minute. This is very important to notice here that whenever the beta blockers are used, if the heart rate is less than 60 beats per minute, so it shouldn't be given to the patient. While it is also contraindicated in symptomatic bradycardia in sign of peripheral hypoperfusions and in case of COPD, chronic obstructive pulmonary disease, and asthma. Another group is hydralazine plus nitrates. So hydralazine plus nitrate, that is dosing. Hydralazine is started at 25 milligram per oral, titrated up to 100 milligram per oral TID. And isosorbide dinitrite started at 40 milligram for oral TID. You can say it can be according to the condition of the patient and decrease the mortality, lower the rates of hospitalizations, and improve and the quality of life. Now come toward digoxins. As we know that digoxin is also one of the best choice which is used in the treatment of CHF, congestive heart failures. So it is very easy to understand and clear the basic concepts. Digoxin can be given to the patient with HF to control the symptoms such as fatigue, mean heart failures. Mean digoxin can be given to the patients with heart failures to control symptoms such as fatigue, dyspnea, exercise intolerance, shown to significantly reduce hospitalization for heart failures but no benefit in terms of overall mortality. Other important medication in heart failure, so that is statin. So statin therapy is recommended in congestive heart failure for secondary prevention of cardiovascular disease. Some studies have shown a possible benefit specifically in HF means heart failure with statin therapy. So improve LVA, left ventriculars, and then reversal of ventricular remodeling, change in size, shape, structure, and function. Reduction in inflammatory marker, so that is CRP and interleukin 6 and TNF alpha 2. Now the medicines or the medication to avoid in heart failure. So now there are some drugs, so it must be avoided. So they are strictly forbidden, so it cannot be used, it cannot be recommended during heart failures. For example, so instead non-steroidal anti-inflammatory drugs, so it can cause worsening of the pre-existing heart failures. While thiazolidinediones include resiglitazones, which is available by trade name Evendia, and 5-glitazones ectos. It can cause fluid retention that can exacerbate the heart failures. Moreover, metformins. Metformins, people with heart failures who take it or it increase the risk of potentially lactic acidosis. So all these drugs should be avoided in heart failures. Now let's see here. These are the other important things, especially implantable cardioverters or defibrillators for heart failures. You can see here, this is a dual chamber ICD device. Implantable Cardioverter-Defibrillators, that is ICD stand for Implantable Cardioverter-Defibrillators. It is a sustained ventricular, whenever there is sustained ventricular tachycardia, is associated with sudden cardiac death and heart failure. So about 1/3 of the mortality in heart failure is due to sudden cardiac death. The patients with ischemic or non-ischemic cardiomyopathy or NYHA class 2, 3 heart failures and LVF that is less than or equal to 35% have significant survival benefit from an implantable cardioverter-defibrillators ICD for the primary prevention of ACD sudden cardiac death. So I mean that this dual chamber ICD device or you can say defibrillator should be implanted, especially in this area. That's why you can see the location of the heart, which is located posterior to the sternum in the mediastinum cavity. So this was the end of my lectures. Thank you so much. Wish you all the best. So if you have any question regarding this lecture, so you can text me. So I am always available for your service. So before watching this lecture, so kindly subscribe it, watch it, and press the bell icon for my upcoming lectures. Wish you best of luck. Thank you.